Well, good afternoon, everyone, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. Just a couple of brief announcements. In order to receive credit for attending today's Grand Rounds, please fill out the evaluation in the Survey Monkey that came with the Grand Rounds announcement from Karen Lambert on Monday. Grand Rounds will be on Zoom for the rest of the academic year, but we are planning to come back in person in September. Of course, it will always be available on Zoom like it was pre-pandemic for people who can't make it into the auditorium. If you have questions for today's speaker, please type them in the chat function and we will forward the questions to the speaker at the end of his talk. Next week's Grand Rounds on April 21st will be given by Yael DeVere, who is our Vice Chair for Child and Adolescent Psychiatry. And the title of her talk is Access to Child Psychiatry, Challenges and Creative Solutions. It's my pleasure to introduce Dr. Brian Skaheen, who is the Director of Child and Adolescent Psychiatry Training, Director of Child Emergency Mental Health and Child Consult Liaison Psychiatry, and Director of the College Mental Health Program, who will introduce today's speaker. Brian.
Thank you so much. It is my absolute pleasure to introduce Dr. Jeff Bostic, who was kind enough to meet with our fellows earlier today to talk about his career path, and I know they enjoyed hearing from you and meeting with you, so thanks so much. I think it was only a couple of years ago that you were at our retreat telling us about school psychiatry as well. And so we're glad to have you back. Dr. Bostic got his undergraduate degree from Baylor University before getting his educational doctorate at Texas Tech, and also stayed at Texas Tech for his medical education, doing internship and residency at the Timberlawn Mental Health System at Baylor Medical Center before coming to MGH for fellowship, where he remained as the director of school psychiatry from 1996 to 2016, before moving on to MedStar Georgetown, where he currently resides. He has worked in over 50 school districts in Massachusetts and New Hampshire, and currently working with over 40 in the DC area, and has taken on an interest in well-being. And I can't think of a better time for us to talk about clinician well-being, as many of us have been exhausted and burnt out over the last couple of years. And so today he's going to speak to us about clinical applications of well-being practices and how it can help all of us and our children. So without further ado, Dr. Bostic, thanks so much.
Thank you so much, Brian, and I'm so grateful to be here. I apologize if you hear wind blowing behind me or other things. I'm not in the office, I'm out. It's been a wild couple of weeks, so we've struggled to try to make sure that everything will be hearable and seeable today. I do want to acknowledge that a couple of people have helped me in the presentation today. Celine Dimitrovich is our researcher who is doing our evaluation of our well-being program, and I'll specify the stuff that she's doing in a bit. And the same with Allison Neuwirth, who has helped us with one application that I think will be interesting specifically to the child psychiatry people in attendance today. Again, I'm from Georgetown at this point in time, but I spent most of my time up in Massachusetts. I worked with McPat for a number of years, which, as I pointed out to the fellows this morning, originated there in Worcester at UMass. And I think that's quite an accomplishment that should always be recognized. There are now 46 states, 2 Indian tribes, and Guam and Puerto Rico who have adapted the McPat model. So it's a wonderful thing that has really expanded care access for everyone. Okay. And I just want to mention that today's presentation, there's no real conflicts that I think would be relevant to this. The program that I'm going to describe to you that we have at Georgetown is free. It's not anything that we're trying to sell anyone. So again, there's no conflicts that we're for this particular presentation. Our learning objectives today will be to recognize a couple of measures that are useful for well-being in both clinical and non-clinical populations. I'm going to tell you some strategies about improving well-being in several different domains of well-being. And then we'll describe how this can be applied to psychiatric practice in several different ways. So to start this off, though, I'm going to talk about burning the candle at both ends, right? And we'll talk about clinicians. And the big term that comes up, of course, is burnout. And I just want to clarify that burnout is what many of us have readily recognized and worry about or actually have experienced, particularly in these seemingly last several years. But by this, it's not a new concept. It's been around since the 70s at least. And it refers to our inability to function in our job because we're burned out. We're just prolonged and extensive job-related kinds of stresses that have taken a toll on us. Now, as it's been broken down further, there's really three components of burnout. And those are emotional exhaustion, which is basically where a person, here we talk about teachers, but in general, clinicians as well, they just can't offer any more of themselves. They're just worn out. They become cynical. It's like, I really don't look forward to seeing people. I don't feel like what I'm doing with others is really all that gratifying anymore. And I'm not even sure that psychiatry is all that helpful or whatever you might be doing. And then finally, a sense of inefficacy, that it's like, even when I'm meeting with people, I don't really know that I'm doing a meeting real good. And so I just don't feel effective. And it's hard to even motivate myself to do this stuff anymore. So this wearing down, exhaustion, becoming cynical, and not feeling like you're accomplishing stuff are really the three hallmarks of burnout. The big inventory that was devised for this really started back in the 80s. Christina Maslock and another woman named Anderson put together multiple versions of this inventory. And they had some slightly different terms. So you see over here, like the PA, that's accomplishment, which again would be the antithesis of inefficacy. Depersonalization, which is the D here, which would refer to an item that would measure that cynicism that we talked about, or I mentioned, and then the emotional exhaustion here. So you can see the types of items here that are used to capture this. This is a physician-specific one. Again, there's a number of versions of the Maslow burnout inventory. We're actually still using it in some of our work. But the point is, you can see the types of items here that are in this. Most of these are, again, Likert scale rated. That's the way that they're provided. And again, there's versions for healthcare workers. There's versions for a variety of different professions. This is just the physician one. I'll mention that this wasn't figured out or created based off some conceptual approach. Rather, it was done through a factor analysis. That is where you put a bunch of items together and then you give them to people, and then you basically look and see which of the number of items that you have tend to kind of separate orthogonally, is kind of the way that they describe it, to see if you can identify factors. And so that's what they did here on this a number of years ago. So that's how it was devised. But again, this is one of the popular things that you'll hear about and that you'll see used in this type of work. Burnout has been something that has been most typically applied to people in the helping professions: social workers, teachers, nurses, lawyers, physicians, et cetera, police officers as well. And it's where it's just the work is highly emotional and it's very stressful. It's where people are really struggling mightily, and it also impacts us in terms of hitting us hard in our own emotions. I'll mention that the most recent Medscape, a very highly touted survey, I'm being a little bit facetious here, has been used to look at every year physician burnout. And so in this particular one that came out this past January 2022, psychiatry is not at the top. As you can see, we're down here pretty close to the bottom here in terms of the number of physicians that reported being burned out. Only, a little better than a third are like, I'm done, I can't do it anymore, I don't even know why I'm doing this stuff. So it's not as bad as, again, being as you would expect in emergency medicine or critical care medicine, which has been really rough the last couple of years. Also importantly, looking at 2021, we were at 41% then. So I think we were more struggling during this interval before, we've started to come out of COVID. So I think the uncertainty of that probably was harder than it is right now. So we've actually improved as far as the numbers of us that are feeling burned out at this particular point. What actually causes people to feel burned out? It's not new stuff. If you look down here at the bottom, you can see that the COVID stuff down here is about 10 to 12% for a couple of different things, the impacts it's had on our life and where we stand with each other, literally, and also the stress of taking care of people with COVID. That's been difficult. But the big things that really lead to burnout have been going on for a long time, for years, far preceding COVID. So it's the bureaucratic tasks specifically that most people hate. We call them prior auths, where I am in right now in Georgetown. But of course, there's many other things like that that are very difficult to keep up with and that really kind of lag us down. I think most of us more enjoy the gratification of patient care, but it's the keeping up with all of the ancillary stuff that's still been tough. But also the lack of respect, has diminished for many of us relative to what we perceived it to be in times earlier. Many of us feel like we're working too many hours. We feel like we've lost control of our lives. We're not sure that it's worth what we're doing. Certainly the computer parts, while they've been well intended and have tried to make our lives easier, most of us are still struggling to be efficient with our use of our electronic health records. So those kinds of things have been tough. Also, though, patients sometimes now are more, I don't want to say demanding, but expect better from us. And in some ways that's good, but in some ways that can also be stressful. And certainly we deal with governmental regulations. So these are the main things that tend to lead us to feel kind of burned out. Oh, excuse me. I want to mention that there are other studies besides Medscape. This one is from the Mental Health America National Survey. This was looking at healthcare workers overall, but this was more of people who chose to fill out this survey, who probably had more of a reason for wanting to complete it. And so the numbers were even higher. But again, this was looking at healthcare workers. So healthcare staff within a hospital, nurses particularly were the second highest group in there after hospital staff. And the numbers here were even higher, not just for burnout, but for feeling worn down, worn out, emotionally overwhelmed. And of course, all the other components that surrounded that, like they worried even more if they had children at home that they were going to get infected or that they were neglecting their children more because of COVID. And so there were a number of things that have made it really difficult. So the point is no one is getting out unscathed. All of us working in this have felt like tremendous duress working in healthcare right now, and particularly during this COVID interval. Burnout is not good. There's a real piece of science for you. What we know is at a personal level that certainly when people feel burned out, it spills over into their other spheres of life, into their other relationships. So divorce or separation or conflict are more common, use of substances, becoming discouraged, even suicide, of course, is one of the sequelae sometimes of feeling burned out. Professionally, of course, it's also really prominent in terms of the negative impacts of burnout, right? Decreased quality of care, more errors, patients feel they can feel it from us also. We're not as productive and people leave. The quote, the old adage going back to, I believe it was Blaise Pascal some 4 or 5 centuries ago, was that all movement is precipitated by dissatisfaction with where you currently are. And so when people are in a situation where they don't feel like they're being productive, they feel like they're just worn down, that probably is an inducement to switch, to do something else, but not necessarily to always go to a different place to do the good work that we're used to doing, but to just stop altogether and do something completely different. The impacts, again, have been very specific in terms of the impacts in terms of on the system when a person is burned out. Not only does care diminish in terms of quality and everyone is dissatisfied, but also it costs a lot. It costs about 2 to 3 times the salary of a physician to replace one. By the time you do a search, you take the time and form a committee of people to interview and see that person, to attract that person there, to configure whatever is necessary to enable that person to actually work there. So it's not insignificant when a person becomes burned out and just leaves. And we know that for each point going up on that Maslow scale, for example, there's a substantial increase in the likelihood that they're going to work worse. They're going to work less, and they're going to put less value into the work they're doing. This is the work from Shanafelt at the Mayo Clinic. They've stayed up on this pretty well. And in doing that, we've also seen that there's been an increased understanding or sophistication to how we look at burnout, and that it's like, well, it's really kind of a component of compassion fatigue that fits under our quality of life. So Beth Hudnall-Stamm here is kind of like giving us a little better description of this now, which we'll see become relevant when we're talking about well-being. And so when we look at professional quality of life, right, we like to feel like we're doing good things for human beings and that we're making life better. And that usually is inspiring to us, right? So we have some compassion, satisfaction. What we're talking about here, though, has been the burnout, the specific thing that's a component of compassion fatigue, but also there's a secondary trauma effect. That is when you hear about people in difficult circumstances, or you see someone come in a traumatized kind of state, it's hard to let go of that. And so we experience, if you will, vicarious trauma by hearing or seeing about the traumatic or difficult adverse circumstances of other people. So to be real clear and to maybe simplify it a little bit, oftentimes we think of burnout when you get hopeless and you just feel like you're not being productive. Whereas with secondary traumatic stress, you just become afraid. You become fearful of seeing things. You worry about the next person coming in. You worry about how they may resemble, or other things may resemble other patients that you're seeing that you may also feel hopeless about. But fear is kind of a significant component here that emerges with the secondary traumatic stress component that's been added in here. All right, so what are we doing about this? How do you measure this stuff now, both the compassion satisfaction and the compassion fatigue? Well, again, Beth moved forward with the infamous ProQual scale, the professional quality of life scale. And this is the one that you probably hear of used the most now. So the Maslach is still used for burnout, great. But the ProQual, another free instrument, is available with 30 items for measuring both the positive and the negative aspects of our care. Again, there's multiple components to this, the compassion satisfaction and the compassion fatigue part. And then within the fatigue part, there's a couple of subscales to look at burnout and secondary trauma. Now, don't be afraid when I show you this next one. Yes, I realize that you can't read this. I'll be glad to provide you the slides here. But more importantly, you can also just frankly look these things up via the internet and see them. These are, again, freely available. And so you can see the actual items here. And so in this particular one, the ProQual here, there are a number of items here that are associated with all those different kind of components, compassion fatigue, compassion satisfaction. And within that, again, within the compassion fatigue part, the burnout, as well as the secondary stress part. So this is a simple mechanism to use to get some sense of how people are functioning regarding their relative satisfaction versus their fatigue and proclivity toward burning out. So what are we doing? Well, we're looking at this also the other way. In that Medscape survey I alluded to a bit earlier, they did ask, well, what are people doing about this? And so not surprisingly, we find that a lot of physicians identify that they actually do physical activity. They do exercise, which is very helpful, right? It increases brain-derived neurotropic factor, as we know in the exciting world of psychiatry, which is itself a useful thing for brain healing and for minimizing your vulnerability to psychiatric illness in some ways. But some of the other skills here are not so much the best. People can withdraw and isolate from others so that they don't influence other people, but this is typically not one that we're hoping for that people employ as their coping skill. But talking with others is, particularly other people who are in the same boat, that is, they're in the same field or they work in the same place. You know, getting those kind of reality checks is actually quite helpful. Again, we'll talk about this much more specifically in a moment. Many people find that they try to sleep. We don't mean to just sleep through stuff, but to try to just get some regular sleep, which is, again, very helpful for the body. Listening to music has turned out to be a real prominent one, and this will have funny iterations here in a moment. But again, some of the other ones, not such good things. We're not in any way thinking that eating junk food is a good coping mechanism, nor drinking alcohol, nor binge eating, or using prescription drugs, smoking anything. These are not. So as we see here, there's a lot of coping mechanisms that people describe using, but not necessarily good ones. If you look at it in reverse, if you say, well, what are you doing to stay happy? What are you doing to like work on your mental health? Then people are more inclined to say, well, yeah, I spend time with other people and that I find gratifying. I do things that I enjoy. Again, I exercise. I try to make sure that I get sleep and I eat better. And a small number of people, 1 in 10, if you will, less than that actually, will talk about doing therapy. So again, the social part of life, the doing things that intellectually keep you like fascinated, physical stuff here, exercising and sleep and eating well, all those things, again, kind of rise to the surface here anytime you do one of these kind of surveys. All right. So what's really happened is, right, we talked about burnout 50 years ago, and then we started talking again about compassion satisfaction and compassion fatigue, right, sophisticating the model, if you will. And then the World Health Organization started moving this forward also. So initially, the World Health Organization would talk about wellness, which was really focused mostly on physical health of people around the globe. But then they switched that term to well-being, which is hyphenated, by the way. People always ask about this. And they describe it as being kind of the physical, emotional, and social, aspects of life and well-being, not just physical, but adding emotional and social. Okay. And it's not just the absence of illness that's associated with well-being, but again, are you doing well physically? And are you doing well emotionally and socially? The Centers for Disease Control here in the United States tried to kind of like take it a little bit further. And so they added a couple of dimensions here, including economic well-being, as well as separating emotional and psychological here into two different things. Now, for us, I can just tell you, giving this away a little bit, we've looked forward at the physical sphere as being one domain of well-being. We moved economic because we're not really financial advisors, but rather we moved that over to occupational and the workplace. And what does that do to you being in a system? And how do you navigate, manage, and improve your organization that you're in? But then social, which is oftentimes outside as well as inside work. Emotional, that's an important thing to be able to emotionally regulate. And then psychological, we moved over to more in terms of intellectual and how do you derive meaning from your life and the minutes that you spend on this planet. So those are the things that we've kind of morphed a little bit from this original work done by the CDC. The World Health Organization did come up with a very simple scale that people use to look at wellness / well-being. They've moved it forward to well-being. Again, so they have their little 5-statement scale here that they use. And if you look at this, really the first couple here are about like emotions. Am I calm and relaxed? Am I relatively happy and having positive emotions? Am I physically in good shape? I'm feeling fresh and rested. And am I active and doing stuff? And then am I doing things that interest me? Which again, we feel more as like in that intellectual kind of realm. So again, these things are all converging is kind of the point of this story. Now, the CDC, the Centers for Disease Control, took a different approach, which is instead of creating their own measure for this, they've integrated multiple measures. And again, this is too many to remember. We've borrowed some of these in our own work, but the entire point of the story is there's a number of things to try to get at how you would measure well-being in various kinds of populations. So where does that leave us? Well, down at Georgetown a couple of years ago, we decided that because burnout was so pronounced in teachers, the average life of a teacher working in the urban schools of Washington, D.C. was about 3 years from when they first started. Now, people that survived those first 3 to 5 years were more likely to continue on for a span longer, but we lost a number of teachers at about 3 years. So the goal was can you go in and create something to help diminish the burning out of our teachers so that we can retain them longer, because it costs a lot to replace them. So we created a program. So first of all, WISE here stands for well-being in school environments. And that is what WISE stands for. So we created this program, and you can literally go to this website, medstarwise.org, and you can download freely our teacher well-being workbook, which is about 200 pages now, and it's evolved over the last couple of years. But that's what we created to try to manage this circumstance with. And then we did a number of sessions with teachers in the greater Washington, D.C. area. We did a 10-session program basically through the course of the school year. So we would meet once a month and go through these domains of functioning with them as we would try to provide them with well-being strategies to manage whatever was going on with them. So the first thing that we did was we went through and we helped them identify how they were doing in these 5 domains of functioning. So if you look, it's like a 25-item scale here, and it breaks down nicely into physical well-being. So do you sleep? Do you eat? Do you move around? Not just exercise, but also not be sedentary. And do you include music as part of your life? Then it was the occupational part. Is my work fulfilling my sense of purpose? Do I stay focused? Do I manage my time well, etc.? Then this is the intellectual part. These items here, 11 through 15. 16 through 20 here are the social parts. Do I feel like I have support of others? Do I get input from others? Do I feel like seeking out other people instead of isolating? And then finally, the emotional part. Again, Can I tolerate painful emotions? Do I feel good? Et cetera, et cetera. So conveniently, that spells POISE, POISE. So this is our POISE Wellbeing Self-Assessment Skill. Again, derived basically from the work that we'd seen most evolving with the Centers for Disease Control. We devised these questions, again, working from the previous work from them. All right. So then from that, we wrote up like, how would you actually do specific coping strategies for each of these things where you might have had difficulty? All right, this is too hard to read, so I'll break it down. So when we looked at the physical part here, we all know that sleeping more than 6 hours a night is really important for adults. Usually 8 hours is preferable, but between 6 and 10 is helpful for most human beings. You can smell vanilla. That helps fall asleep more easily. Some people need sounds of fans or white noise or the sea, whatever. You can read before you fall asleep. You can take advantage of the mammalian hibernation kind of tendency that we all have. So if you make the room cooler, down to between 60 and 70 degrees, that's really helpful. And you can do things again, like not using your snooze that wakes you up every 5 minutes, but instead doing it like 30 minutes. You get actually some better quality sleep. There were a couple of other funny things in here, in terms of eating, replacing food with better food. And I'll talk about the blender stuff in a second. And then also the movement stuff, because there's a couple of funny cultural things that jump in here. So specifically, a blender is probably the most fundamental cooking device, I'm using that term loosely, that we now have. We know that we're supposed to ingest spinach and kale and other things that just seem not all that appealing to us. However, if we put pineapple or blueberry in with kale, spinach, whatever else, it actually makes it drinkable, tolerable. So the entire point of the story is that it's going to be a matter of blending things together and trying to use these. Ironically, I purchased a blender for our child and adolescent psychiatry fellows at Georgetown, but dadgummit, right around the time that COVID hit. So we haven't been able to actually use it yet, but that is our plan in coming weeks and months to do that, to figure out what concoctions and things are most attractive, but are included in things that are healthy. So this is not a complicated thing to do, but having these as one of your snacks or even meals once a day at least is probably a far preferable option than what most of us are doing. And again, there's ways to make it actually work. Exercise. Now, this is a funny thing. We were just joking this morning, Dr. Yonkers and I were about mutual friends that we had back at UT Southwestern, where both of us worked at different times in the past. And we talk about yoga up in Massachusetts and even in DC, and that's pretty palatable to people. But down south, we have to be more cautious about that and sometimes use terms like, these are football or basketball stretching exercises. It accomplishes the same thing, but being able to have movement and to move around is a very important thing, but it has to be a little bit culturally attuned to be attractive to people in different areas. On the occupational sphere, I'll just mention that most of this at the time was focused on how do you manage your time? How do you deal with demands placed on you, like saying no nicely to other people? How do you manage procrastination? How do you keep up with stuff? All those kinds of things. What we've really found has expanded, and I'll talk about this more in a moment, but Destiny brought it up this morning when I was meeting with the Child Fellows, is the importance of recognizing the influence of the workplace itself, and sometimes implicit or explicit, either racist kind of practices that may be going on or other things that are not really forward thinking in terms of structural components that persist that are not equitable to people. So we've actually expanded much of our stuff to address that, which I'll tell you a little bit more about in detail for the occupational sphere. I'll also mention, though, within this, that one of the things that's really become prominent has been the work of Cal Newport. Now, he coincidentally is at Georgetown. I don't know him. I've never seen him before. We've never interacted, but he's written a number of books now that are quite good on how to manage all the devices in one's life, how to keep your computer and your cell phone relegated to places where they minimize the negative impact of intruding on our lives. So the point of the story is, we found his work very helpful, and we would encourage others to look at it. Most of the people that I've foisted this off on, that'd be the Child and Adolescent Psychiatry Fellows, have preferred this book, Digital Minimalism, as feeling like this has given them very concrete, practical strategies for how to manage their schedule better in specific ways, and also, again, how to peripheralize devices so that they can be more engaged and more present for other things that go on during the day. On the intellectual and social spheres, again, intellectually, we want people to be doing things that stimulate their mind, that keep them engaged, that keep them in the game, that keep them excited about topics that they're working with. And again, the metaphor that we've most frequently used has been, there's only so many minutes in your life, and you have to decide how those minutes are going to be allocated. And it's too easy for us to get trapped into the circumstance of doing all the tasks that we feel like are imposed upon us, such that that's what we actually get good at, are responding to tasks and taking on more tasks. And we don't do the things that really fit with our core values. And so it's been real important to rethink about that and to create time, to schedule time, to build in time to do those things that you most value. Many of us will say that our children or our family members are the most important thing to us in this world. And yet we don't really allocate the hours spent with them to make sure that we're doing that. We were talking some this morning. We were engaged this past week with the refugees from Ukraine who were now in Poland. And one of the important things there was the Ukrainians are striving to keep up with what's happened to their extended family members in various parts of Ukraine. So they're watching television frequently to keep up with the war situation. And of course, that's unproductive. It's not helpful, as we know, to watch multiple hours of news stories showing bombing or difficult things that are going on. And so the point is that we had to literally go in and try to talk about how various people in the family could monitor at different times throughout the day the things that were occurring there in Ukraine to monitor safety and extended family members' circumstances, but to also use hours to continue to do things with their children, those things that most matter. So it's difficult sometimes in the midst of adversity to continue to prioritize the things that are most important to all of us. And then socially, again, seeking input from other people. You know, we talk about making sure that you say 3 good things for every negative thing that you say to your kids and your spouse and so forth. The better number is about 5 to 7 to 1, particularly in the workplace, to sustain energy and effort from others. We know that when that number exceeds about 10 to 1, that people start to wonder if you're being genuine and authentic. So anyway, there seems to be a sweet spot with that. I think it's pretty familiar to most of us to talk about ORs, right? Open-ended questions, affirmations, reflections, and summaries when other people are speaking to us. So rather than immediately problem solve, just demonstrate that we're hearing them, that we're eliciting more information from them. That really increases our social bonds. And then again, recognizing our own triggers, things that set us off so that we don't so quickly respond to someone in an impulsive way that may alienate us from others by frightening them. And finally, on the emotional sphere, you know, we've talked a lot about what we now call our thrive and survive emotions rather than good and bad emotions. So we want the thrive emotions, things that make us serene, hopeful, awed in our lives, to experience love, joy, to feel inspiration and gratitude. But we also want to cherish in some ways our survival emotions, right? Fear, regret, envy, shame, hate, anger, those kinds of things, because those survival emotions are the things that make us aware at an internal level that what we're doing isn't working for us, that we should change course. And indeed, back to Pascal, we need to do something different. We don't want to stay locked into survival emotions. We want to use them to bounce back toward things that make us feel serene, hopeful, etc. Those thrive emotions, but we want to recognize the value of those survive emotions when they do emerge. And then again, you can't tell people to stop doing anything. You have to tell them what you can do instead of that. So alternative activities to manage stress, etc. Reframing, is there a value in something that's in front of me? Again, particularly for people who are spiritual or believe in things beyond themselves or just altruistic, saying, wow, this adversity is on my path, this patient's in my path, and they're really difficult, but they're in my path. There's some reason that I'm supposed to see this person and do something with them that really will matter. Okay. And of course, problem solving does remain an important thing to do. And again, getting reality checks from other people who similarly can appreciate your predicament. And of course, we're always trying to live more in the moment rather than in the future or in the past. Okay. So when we ran this through with our first cohort of about 40 teachers in the Washington, D.C. area, what we found was they all valued it, right? They all thought that teacher well-being was a useful thing, but what did they really do? And you see that the numbers start to drop off. And my favorite thing was they were like, yeah, don't tell me to go to the gym or healthy like stuff that I can do. Even when we practiced doing yoga at the beginning and the end of every session during our 10 sessions with them, they were like, yeah, this is not stuff I really feel all that immersed in. And it turned out that a lot of them said, I already have my quote routine that I do for walking or going to the gym. So that's less important to me. What we were shocked by was the importance that they ascribed to music and how much they wanted to embrace that in their life. So a little bit of a surprise there with that. But these components, again, of physical well-being were all important, but as you can see, some were valued by these teachers more than others. They very much appreciated recognizing stress, what to do to manage emotional stress and their triggers, and how to get along better with others. Again, we found that they wanted more on how to deal with working in a toxic or difficult or complicated environment. Did they think it was helpful? Yeah. So again, certainly people found like this is a valuable thing to do, but again, it was trying to make sure that we were addressing the things that really were valuable. So I want to mention the music thing. This is Serena Williams. And if you haven't seen this before, she and most other tennis players, a lot of athletes have figured out that music is really relevant to them, not just so that they can calm down and be in a good place, but it also improves performance. So if you're trying to encourage people to listen to music and they're resistant to that, know that this is a big performance enhancer. And I'm going to have several funny jokes about this. They're not really jokes, but they're funny things and ironic things to me. The first one is that it turns out that this was discovered in 1911 in New York City when they were doing bike races that went on for days. They found that at certain times the racers all went quicker, and it wasn't based on like the terrain, like where you going uphill, downhill, flat, whatever. It was where the marching bands back in 1911 happened to be stationed. The bikers, the cyclists went faster there, about 7% faster than they did in other places. And so wherever the band was playing, the cyclists went quicker. All right. So the truth is that athletes quickly figured out that music is a good way to like keep your cadence going. So much so that I hope you will take pride in this. The Boston Marathon outlawed music for runners to use when they were running the Boston Marathon in 1986. They said it gave people an unfair advantage. Now, I hope you'll appreciate this. They no longer try to enforce this because even in 1986, what really happened was the runners simply went out and got their friends all along the 26-mile course to get on the rooftops of buildings and to blast the tunes out that they liked on boom boxes. So the point is like, this is like a real integral part of performance enhancement that athletes use all the time. So again, just want to mention those components of the benefits of music for people who are otherwise like, kind of about it. And again, this is 1911 when Lou Ayres figured this out. It just cracks me up. Now, if you're one of those people who are like, but I don't really know where to find music, I just want to mention there are a number of free platforms out there where people can identify music that is like the music that they already like, or that will identify the song. What song down here is for this that you have heard, but you don't know what the name of the song is. And my personal favorite is for people who are like, I don't care what music I listen to, as long as it's not Def Leppard, or as long as it's not Justin Bieber. You can type that in this particular platform will identify music that is seemingly the opposite of the music that you type in. So whatever you hate, it will give you the opposite of that kind of music. So the point is there's a number of platforms that will help you find this stuff. The other thing that we found really fascinating as we went through this was the importance of motivational interviewing. And so the joke is people could look up and go, everybody would acknowledge exercise, that's good for me. But yeah, by the time I get in, it's too late to want to do it. I'm tired. I'd rather watch TV. I don't want to have to like get sweaty in different clothes that I put on. So all this stuff would just outweigh the benefits of something that clearly was a good thing. So again, it was real important to address the various things through motivational interviewing kind of techniques to get people to actually employ like well-being kind of strategies. And similarly, it's not the number, it is the valence, right? There are sometimes things like I'm exhausted when I get in, so I'm not going to get up and go do exercise stuff at that time. So what does that really mean? This is what it really meant. When we were working with teachers, we found that a very helpful thing to do was at lunchtime, instead of eating lunch while they were sitting there, they could eat and or talk while they were walking around the building and whatnot, so that they could get a little bit of physical movement doing that. And so for any non-confidential kind of meetings, in fact, we encourage them throughout the day to walk with other people around while they were discussing stuff that, again, was non-confidential related. There are a number of reasons, of course, that people don't want to be or do well-being practices. You know, they're like, and I have to tell you, this was a true one. I brought in protein bars of all different types so that people could just experiment with those and see what they liked, including cricket protein. I don't know how many people have ingested cricket protein, but we did that just for thrills. But people were like, Boz, this is all good, but you know what? I like Cheetos. I like my corn puffs, and I'm not giving those up. And it's like, some of these things have a real integral part of people's lives. And so we just have to acknowledge that. But again, from an MI standpoint, a lot of things get to people's core values and enable them to make a little bit of movement on this. I do like to sleep. I do like to eat lots of different kinds of foods and try lots of different things. And I do want to live to see my grandkids. So yeah, I guess maybe I should clean up my act a little bit and do some healthier things. We found that going through both of these things actually improve people's receptivity to doing well-being practices when they weren't familiar or particularly valued. All right, this is a big thing. One of the things that we found along the way is that some terms like resilience and grit, which were vogue maybe 10 or so years ago, have come on to take a different meaning right now. And I say that with a degree of extreme seriousness in terms of what they have represented. And by that, I mean, resilience has sometimes been used along with grit for a way of, you know what, you're just supposed to suck it up and tolerate something that's not good. You want me to just gut it up and tolerate this rather than actually address the systemic contribution to this ongoing problem. You want me to contort into what your vision is of what a faculty member should have been 30 years ago, Boz. Well, maybe something other than the way that you're used to doing it would be preferable. So there are times to change direction rather than just persevere. Grit, by definition, is passion plus perseverance. Well, sometimes just persevering should give way to, can we do this in a better way? Can we alter the nature of the game to make it more equitable and fair? So when we looked at this, we found that the things that we did should address both micro and macro levels of difficulty in the workplace, again, around our occupational well-being. So specifically, there may be things that you need to do to manage your work environment and things that will help you manage your time better or tolerate some employees that you don't like particularly so that you can do that. And our metaphor here was, if you live in one place, certain kind of clothes work. If you live in a different place, you need different kinds of clothes. But also things need to be addressed at the macro level. What would you do that would be good for you and for everybody else in this system? And so that again was, maybe we need different water conditions if we're in one environment versus firewood if we're in Montana. That was our very concrete version of this metaphor. And so from that, we really expanded our teacher wellbeing workbook to address whether people treated fairly, whether the workload seemed like it was appropriate and most people could manage it, the role clarity. If you're a school teacher, but also a child psychiatrist or adult psychiatrist, this is huge. Every week it's like, oops, somebody's out, you don't mind covering the inpatient unit, or oops, somebody is out at an IEP meeting. If you're a teacher, we're going to need you to cover that person's math class. So it's very difficult to know what you've got to work hardest on. Is your principal, is your supervisor actually helpful in providing you useful input or not? Again, back to time pressure. Do you have ways to manage your time so you can get stuff done within the appropriated time? And a big thing that we didn't recognize until we started looking at this was, do people value you? It's hard when you work in a community where what you hear is negativity about school-related kind of work, for example, with our teachers. But similarly for us, when it feels like everybody's questioning what we're doing as physicians, as child psychiatrists, as adult psychiatrists, are we really doing things that are aligned with what's important? I'm not going to go through all these. I'm just going to show you what we specifically did. Again, you can look at the workbook that is freely available to you. When we were looking at the various things here, are you treated fairly again with the worker treatment? Do you trust other people? Does it feel like there's favoritism? Do you have any input on who's hired, who's fired, how you're evaluated? And are the evaluations clear and specific? We look at those macro things. What can you do? Do you have a mentor? Are there things that go on that help you maintain your prideful identity rather than feel like you're being contorted into something else, etc. So we looked at these at the macro level, but also, do we have policies to address this kind of stuff? Do we have ways of monitoring how everybody's feeling about this stuff? Do we have mechanisms to get input from a bunch of us? Not just the improvement box that only one person may see, but ways that we can collectively describe things that we felt like would be needing to be addressed and that would be helpful to move forward. And again, clarifying the processes for contributing to like policy review. So again, we went through each of those domains that I just mentioned to you here, treatment, workload, et cetera, and devised both macro and macro mechanisms here so that people would have concrete strategies to implement depending on where they fit in all this. Okay, now from that, what we did was we created an online version, also free. So again, you should go in and play with this just for fun at some point in time. I know it's for teachers, but you will see readily that all these strategies really apply to humans, which will be funny in a moment. But the point is you can go into this, but the relevant part is as soon as you go into this online version of it, it immediately says, oh, here's where you fit in all these spheres. And like in your physical domain, you're doing good, for example, with sleep, but you know what? Your exercise part isn't so good. You're not moving around enough. So then immediately it routes you, again, because it's an online version, directly to the strategies, the coping skills for that stuff. And then the same thing with all the other dimensions. Like you might look up and go, I'm doing pretty good in several components of my occupational well-being, but not so good in some of the other ones. And so again, you'll get routed to that. So it's a more efficient thing. And the other reason we did this was because sometimes teachers were like, you know what? I don't want other people knowing my business. I'm afraid that if I actually speak out openly about my well-being at a meeting with a group of 10 other teachers, that could influence my rehiring for next year because I don't feel like I trust the managerial staff here in the way that I would wish to. So this is something that people are taking now from Idaho to wherever else on the planet. Again, it's freely available. If you go to that website, you can go in and we're not going to send you a bunch of advertisements or anything else. We would wish for people to play with it and make it better and improve it. So this is what kind of the status that we're at right now. We decided that it would be helpful to evaluate it, big whopping surprise. So we went in and our joke was going from the forest to the trees to the branches and the leaves to getting real concrete about what we did. And then Celine, this is Celine in the middle, winning an award as she often does in research endeavors. This one was for her work in social emotional health. She devised stuff where we went through and we looked at a number of measures and we just crosswalked them as our joke to what things were that we were looking at in our well-being curriculum and to see what things would capture that. And from that, we ended up with 12 different measures and bits and pieces of a bunch of them here to do that. So now as we go through that online version at the very end of it, at the beginning and the end of it, we have these measures that people do so that we can get clarity of what actually gets improved and what doesn't. So again, you don't need to know all this. Again, this is easily findable, outable stuff if you want any of this. All right, what about teachers? Won't other people need this same stuff, like turn the temperature down when they want to go to sleep at night? Of course. The University of Maryland took our teacher well-being stuff and just moved it over to clinicians. So they changed the word teacher to clinician, and they changed other language to make it more appropriate and better attuned to clinicians. But that's freely available at provider.org through their website here. And again, it's completely free. And this is for clinicians. This was devised for school-based clinicians, not child psychiatrists, to be clear, but for school-based mental health clinicians. So there's that version of it. And then the other thing was, we decided that we would start looking at this to use in our clinical practice with our plain old patients, our kids and adolescents who came in. So we modified the POISE to capture that. And so in addition to doing the DSM-5 diagnostic component, it was like, well, what do you do to like build a good brain anyway? We should be doing that kind of stuff. So that's what we've done, and particularly with our psychopharm piece. So we just changed the items. Again, this was in our highly prestigiously published Psychiatric Times article back in October. So it's freely accessible there, but I'm glad to send it to you as well. It's freely available. And I want to mention one of our med students now about to graduate, Allison Newworth, did the work on this. And so she specifically went through and looked at all of these things that we were doing for adults, and then looked at, or teachers, I should say, and then how we could apply them then for students, and then also kind of the resources that we could use for these things so that people would know exactly where to go and that would appeal to both parents and to kids. So again, that stuff was all available from there as well. And again, this is through all the same 5 things. Obviously, occupational for kids is more like, how are they doing at school, right? That's their primary job kind of approach there. But same stuff is the point here. All right, this is where I'll stop. We could do one of the poses from yoga, but we won't do that today since I'm not there. But I'll be glad to entertain any questions about any of this stuff that you have and how we might apply it in our clinical lives.
Thank you so much for that wonderful presentation. I think seeing how burnout and well-being are issues for all of us in this field of mental health right now, both for our patients and for ourselves. Really appreciate your thoughts. There were a few questions. One, can you please post the link for the POISE tool you showed? I'm not sure if that's on the providingwellbeing.org site that you had, or if there's somewhere else, but that was one request. And while we're waiting for other questions to come in, I'm wondering if you have advice for those of us in mental health care who maybe don't want to out ourselves as being burned out. And, you know, people may be looking at me. I certainly have experienced that over the last few months and years, really, for the children's behavioral health crisis. But what can we do kind of when we're in that system and looking around? Most people are like us, and it's hard to come up with giving advice or suggestions that feel authentic and don't feel like they're just passive. What advice would you have for leaders of systems and organizations to help with that?
Yeah, I gotta profess that, we're trying to figure this out as we go, and we're in that same dilemma. I know that our immediate forward step was to take what were these group sessions that we did with well-being and move this again to something that a person could do online and be as honest as they wanted. And they do, it's done anonymously. We don't keep track of an individual person's name or anything like that. So some school districts have actually used this. And so the whole teacher cohort that they have will do it. But again, they're doing it where none of it's going to be traced back to them. So they feel safe in it. So that's one mechanism. I will just tell you candidly that it's not going to be sufficient because unfortunately, we're not Clint Eastwood. Nothing against Clint Eastwood. We're not individuals. That is, humans are herd animals. And my bad joke is that we're much more likely to moo than we are to do like mountain lion kind of noises or whatnot. The point is that we really function better as herds, as groups. So here's where I'm going concretely. All of us have people that we know, typically in the profession, if you will, that we reach out to. And I think it's a little hard, but I think it's vitally important that we find ways to link to other like-minded souls where they don't have direct input on our occupational status. So I was talking with the fellows this morning, and I was like, do you know, like Destiny is going off to Yale. So I mentioned some people that I knew at Yale, but I rely on them a lot. I talked to Andreas Martin. I'll mention him. I'll throw his name out there. He's been a great human being for me to talk with. And we've wrestled with, our own struggles throughout, not just COVID, but our careers, times when we've flourished and not so much. And same with other people. And so I think it's so important that we work together as teams within our institutions, but that we also always broaden out so that we have other reality check people we can talk to where we know that the stakes are low. That is, that this is not going to be politically used in any kind of way where it could be disadvantageous to us. So it's just real important to network. And I have to say, one of the things that I probably most value about child psychiatry is people are happy. Most of us like working with kids. They're going to get better in spite of whatever we do to them. So I think there's joy in working with them. And so I think that it's easy to tentacle out to work with other child psychiatrists and learn from what they're doing all over the place and stay connected to them. That's the key thing, stay connected. It's a small number of us. So it's like finding other like-minded souls, I think can be real helpful on our well-being stuff because of the pressures that we feel right now with child psychiatry. All right. Has your research shown any major differences in effective and common coping mechanisms between age groups? The short answer is no, but that's because we're just now collecting it. All those things that I mentioned that Celine has put together, we'll be looking at here in coming months. We launched that thing back in November, the online version where we're measuring that. So we're hoping to see some of that out. We are capturing age as well as other demographic variables, male, female, so and other things, racial identification, et cetera, because we know that there'll be differences in that. So it's a very important question, and we don't know the answer to that yet. We do know that it's also very different between millennials, Generation Xers, et cetera, already when we were looking at teacher cohorts. So that the materials will have to be kind of adjusted to fit within what's, again, attractive or palatable to each developmental group beyond kids and adolescents, all the way into, like, again, these adult groups, basically at every 15-year interval, 20 to 35, 35, I think it's 25 to 30, I'm sorry, 25 to 40, 40 to 55, and 55 to 70 currently are the demarcations that are being used.
Give a few more moments to see if there's any lingering questions. Sometimes it takes a few minutes to type things in, but it's nice to see how this can be applicable to multiple different domains, and the way that you organize it really gives us some concrete ways to work on it. Related to that, Dr. Metz is asking, will you market this to other groups or businesses and things like that?
There's no plan right now to market it. And I'm just telling you honestly, as old as I am, the goal is to give it away and to get new people, you guys, everybody else, to look up and go, this is good, this is mediocre, and to make it something bigger and better. That's really the objective. Now, that said, out of this side of my mouth, the guy that I work with that's helped do the MedStar site, one of our child psychologists is like, Boz, we have a number of school districts who want someone to come train us in this, same as people come train like for CBITS and those kinds of things. So we're toying with that idea, but we're not interested at this point in time in using it as a financial funding stream in a significant way. But again, I don't think that way. So I'm the wrong guy to really ask. I am going to put my email address in here. Please, if anybody's cautious about saying something in a forum or wants to ask me for any pieces of any of the stuff that we have, I'm telling you, we're trying to, get it out there so that people can use all this. And again, there are absolutely other programs and some that are proprietary. I did not mention those today. That's not because they're not good, but just that right now, I think we're still in the early stages of this. And we're hoping to create more of a network where people are, I'm doing this, you're doing that, what's working, what's not. And hopefully we'll have some data out there about what's helpful so that we can use the best practices that we find. And just like people have said, such that they're developmentally attuned, both for kids and beyond, as well as also attuned to other differences in groups so that they'll be most helpful. So thank you so much. If there's anything else that comes up at any point in time, please don't hesitate to reach out to me. I'm putting my Gmail in here just because you can send stuff and I can send stuff like bigger files, like of slides and stuff, but the Georgetown one, I'll put that one in here as well. They spell my name wrong. I've tried to correct it for years, but it hasn't worked. So. All right, either of those will work. Please don't hesitate to reach out to me for any of this stuff anywhere along the line. Glad to share anything.
Thank you.
Thanks so much. I look forward to hopefully catching up with you at another ACAP meeting or something like that in the fall when we're back in person, but really appreciate you coming.
Same, Brian. Thank you guys so much. Have a great day. Take care. Bye-bye.